ನೀವು ತೇಜಸ್ವಿನಿ ಮೇಡಮ್ ಸೇಮ್ ಅಲ್ಲ ಸರ್?
ಹೌದು ಸರ್.
ಲಾಸ್ಟ್
ಪ್ರೊಫೆಸರ್ ಅಂಡ್ HOD ಸರ್.
ಅದೇ ಲಾಸ್ಟ್ 2 days ಬ್ಯಾಕ್ ನಿಮ್ ಕ್ಯಾಂಡಿಡೇಟ್ ಅಲ್ಲ ಪ್ರೆಸೆಂಟ್ ಮಾಡಿದ್ದು. ದಟ್
ಸರ್.
ದಟ್
ಮೇಡಮ್ only introduce sir.
ಹಾ, ದಟ್ಸ್
Friends, a warm good evening to all of you. We are happy to invite you for this edition of the Friday PG Clinics. We have 2 important cases kindly contributed by Dr. Professor Srinivasan sir and the team at the BM Patil Medical College, Vijaypura. Manjunath sir and Tejaswini madam have kindly contributed. And I also warmly welcome the invited faculty, Professor Birappa sir. Somprakash Basu sir will be shortly joining. Professor Jignesh also will be shortly joining. Professor Santosh Anand is the first time coming to our group, kindly introduced by Dr. Srinivasan sir. He right now is PG faculty at the GEM Hospital's Surgical Gastroenterology Department. He is like I would say, excellent student of Professor Srinivasan. He has had his master's from the All India Institute and later MCH from the JIPMER, and he is now a practicing surgical gastroenterologist and faculty at the GEM Hospital. Professor Birappa sir is always a willing person to help us whenever we ask. He immediately agrees to teach. Thank you, sir, for joining us and honoring us for this evening. And we have our own academic committee team. Professor Shanai sir, Professor Rajiv Sakai sir, Srinivasan sir. I think Karnakaran sir has something come up in the family, so he has excused himself. I hope others will also be joining shortly. So with that few words, I invite Dr. Arun Pandey to start his presentation first.
Good evening, sir.
Please introduce yourself and about your unit chief, then you are head of the department, and start your presentation. Over to you, Dr. Arun.
Good evening, sir. Good evening, teachers. Today I will be presenting a case of mass in right hypochondrium under the guidance of Dr. Tejaswini Vallabha ma'am, who is professor in our department. Our unit head, Dr. Manjunath S. Kotanawar sir, Professor, Department of General Surgery, and our HOD sir, Dr. MB Patil, Dr. Anand Patil sir. I am final year postgraduate in Sri BM Patil Medical College Hospital and Research Center, Vijaypura, which is a BLD deemed university. I'll share my screen, sir.
Make it full screen, Dr. Arun.
Yes, sir.
Please switch on your video.
Can you see my video, sir?
1 second, ma. Yes,
Yeah,
ma. You are going good. Start.
Good evening, everyone. So, starting with patient details, my patient named Mrs. X, aged 55-year-old female with poor socioeconomic status and Hindu by religion. By occupation, she was a housewife. Came with the chief complaints of loss of weight since 3 months, pain abdomen since 1 month, and yellow discoloration of eyes since 15 days, loss of appetite since 1 week. Coming to history of present illness, the patient was apparently all right to start with. She lost 8 kgs in the last 3 months. She complains of pain in upper abdomen, which was insidious in onset, gradually progressive, dull, aching type, aggravated after having meals and reduced on empty stomach, and relieved on taking pain medication for few hours. The patient also complained of yellowish discoloration of eyes since 15 days, which was insidious in onset and gradually progressive, and loss of appetite since 1 week. The patient also complained of passing clay-colored stools since 10 days with itching all over the body. There is no history of fever, vomiting, loose stools, or constipation. Patient has not received any treatment for the same complaint in the past. There is no history of any comorbidities. Past history, there is no history of similar episodes in the past. There is no history of previous hospital admissions. There is no history of blood transfusion. The family history was not significant.
Can you please mute iPhone? I do not know his name.
Coming to personal history, the patient had mixed diet. The sleep was normal. She told of passing high-colored urine, clay-colored stool since 8 to 10 days. She was married 28 years back, has three children, 2 males and 1 female. No history of any addiction or substance abuse. Menstrual history, attained menarche at the age of 14, followed by regular menstruation in between, and attained menopause at 48 years of age. Patient was examined in a well-lit room. After obtaining verbal consent,
Dr. Pandey, just hang on, please. We'd like to ask
yes,
you on
sir.
your history.
Yes, sir.
You spoke about pain. We need a more descriptive. The full Socrates should be there. Any radiation of pain?
There was no radiation of pain to the back, sir.
Yeah, so that has been missed. It's not been there. Also,
Yes,
you
sir.
said the sleep is normal and the patient is having itching. Is it possible? The
Sir,
patient
I
is
asked.
having itching. Will the sleep be normal?
Yes, sir.
So
It
that's
is
all-
unlikely. Sir.
Right. And you have high-colored urine with clay stool. Why do you get
Yes, sir.
high-colored urine?
For the presence of bilirubin, sir, in the urine.
So bilirubinuria, right?
Yes, sir.
Right. So normally you don't have bilirubin in the urine.
Normally we
What's
have
the color? What's the color of the urine then?
straw colored, sir.
Too. Why is it due to? What's it due to then?
Urobilinogen, sir. It will be there.
Right. Okay. And lastly, it is menarche, not menarche.
Menarche, yes, sir.
So please carry on, sir.
And anything in the history, which is also important, in a patient who is complaining of a yellowish discoloration of the eye and passing yellowish urine. Anything in the history you would like to mention? Eye colored urine, sorry.
The patient complained of passing high colored urine.
No, anything more important than urine? Anything
Yeah.
else which you'd like to ask about urine?
I don't know, sir.
It's frothy.
Probably, sir. Okay.
Frothy. So by history, what do you think is are you dealing with?
So dealing with a patient of obstructive jaundice, sir. As the typical history shows, clay colored stools, high colored urine.
What could it be due to? What could this thing be due to? Just by your history.
Case of obstructive jaundice, sir.
Okay, I mean
What
that's
is the color of the clay you are placed?
what due to what?
Arun, what is
Sir,
the color of
It's
the clay?
painful. The patient has pain, right?
Yes, sir.
There's no vomiting,
There is no vomiting, sir.
right? So there's pain and there's jaundice, obstructive jaundice.
Yes, sir.
So what can you narrow it down to? Is there any waxing and waning which you've not asked?
There was no vaccine, sir. Initially, there was no pain, sir. I asked the patient whether she had any history of colicky pain in the past, but she's
But you're
not giving
describing
any
pain,
such
isn't it?
Yes, sir.
So it's painful jaundice,
Yes, sir. This is a painful, dull aching type of jaundice, sir.
right? And in waxing and waning, you've not come to that also. You missed that.
Yes,
Any
sir.
history of waxing and
There is
waning?
progressively increase in the jaundice, sir. In this case.
Okay, but no episode of waxing and waning.
No, sir. She is giving a
How do
short
you
history,
ask
sir.
how do you ask for history of waxing and waning of jaundice?
Sir, whether the color of the urine intermittently becomes normal.
No, it takes a longer time. The patient generally feels better. The appetite returns, feels better.
Yes, sir.
So what do you think is the cause? Painful obstructive jaundice.
So one more thing, any patient with an obstructive jaundice and painful jaundice, you need to mention certain things like a history of fever with chills and rigors. It's
Yes,
most important.
Yes.
It means whether this patient has an cholangitis or not.
Cholangitis and
Even if it's not there, you need to mention that.
yes,
Number
sir.
one. Number two, history of GA bleed or melena.
Yes, sir.
A patient with an obstructive jaundice. The most important. You need to mention that. If the patient has an history of pain in the past, Need to mention that. Of course, you mentioned that there's no similar complaints, but specifically you need to mention there is no history of pain in the abdomen, no medication. So these are all important things.
Yes, sir.
Okay. Yeah.
So the patient hasn't taken any treatment for the same complaint before, sir.
What is the color of the urine here?
Color of the urine is high colored, sir, like dark yellow.
Is it possible to have the patient having a jaundice, but the urine color is normal?
Sir, in case of unconjugated hyperbilirubinemia, it can be there, sir.
Can you give the example of the unconjugated hyperbilirubinemia?
Sir, in case of massive hemolysis of short duration, in case of some anomalies like Gilbert syndrome or Kliegler-Najjar syndrome, the unconjugated bilirubin will be high, sir.
Any hemolytic disorders?
Yes, sir. In hemolytic disorders, it will be there, sir. Unconjugated hyperbilirubinemia will be there, sir. Mostly not associated with high colored urine.
So, can you tell the urine is yellow, but the eyes are not yellow? The reason for that?
No, sir. I don't know.
You don't know any reason for that? Urine getting yellow, and that is one of the commonest thing which happens.
Yes, sir. Dehydration can be there, sir, commonly, but apart from that,
which is the commonest drug which is taken by everyone, almost everyone.
So paracetamol, Bicosol,
Yeah, B complex.
B complex, sir. Yes, sir. B complex can cause, sir.
That will
I was
cause.
thinking of pathology, sir, actually.
Could it be an infectious hepatitis?
Santosh, you want to unmute us.
Could it be infectious hepatitis?
It could be, sir. The associated, but fever episodes are not there, sir. So less likely, sir.
No prodromal symptoms.
Yes, sir.
This patient did not have nausea, vomiting.
Yes, sir.
And the infectious hepatitis patients do have a nausea, vomiting, and pain is very dull, aching sometimes may be
Yes,
there.
sir.
But rest, they may have initially, if the bilirubin is high, they may have an itching. They may have an sometimes clay-colored stools also. So this patient does not have a prodromal symptom. That's most important.
Yes, sir.
What will happen to the urobilins and the urine in this patient?
Yes, sir.
What will happen to the urobilin in this patient? In the urine, yeah.
Sir, the urobilinogen will usually decrease, sir.
Obstructive jaundice, no? It will be
Yes,
decreased.
sir. Decrease, sir.
Okay.
What is conjugated hyperbilirubinemia? How much should conjugated bilirubin be to call it as conjugated hyperbilirubinemia? Hello?
Hello, sir. Yes, sir. More than 3 times the normal, sir.
No. I'm asking conjugated hyperbilirubinemia. To call it as a conjugated hyperbilirubinemia, obstructive
Yes,
jaundice.
sir. So the conjugated bilirubin will be high.
Percentage of bilirubin should be of direct bilirubin. How much and above? Is it 50%? 50?
More than 60 to 70%, sir.
It is actually 15%, 1.5. So normal it is less than 15%. Okay. So what are the factors in your history which favor obstructive jaundice? Just 3 factors.
History-wise, the patient is complaining of passing clay-colored stools, high-colored urine, and generalized itching.
Yeah, these 3 things are supportive of obstructive jaundice. Now, yes, with the history, can you predict whether could it be due to benign or malignant condition?
Yes, sir. As the patient is giving complaints of loss of weight, which is significant in the last 3 months, so we can think of a malignant cause, sir. And associated with anorexia, sir, loss of appetite.
So, what is Courvoisier's law?
Sir, according to Courvoisier's law, if in the presence of jaundice, if there is a palpable gallbladder, it is non-tender. It is probably not due to stone, sir.
Yeah, it is probably not due to stone.
Yes, sir.
Okay.
Exceptions?
Sir, exceptions to Courvoisier's law could be double infection of the stone One stone can be in the cystic duct and one in the CBD.
Double
Can
stones,
be
impacted stone. Yeah.
can be a single primary impacted stone in the CBD, and can be multiple very large amount of calculi in the gallbladder, sir. So the gallbladder will be palpable, sir.
Because
The patient is diabetic.
Status also.
Patient is non-diabetic, sir. Patient is not
Any-
having any comorbidity, sir. No history of diabetes, hypertension.
Any recent onset of diabetes?
No, sir.
why that history is important.
Why?
Sir, supposedly, if we are thinking in the view of malignancy, especially involving the periampullary region or involving the pancreas to be specific, sir. So there can be recent onset of diabetes associated with it, sir.
Or if the patient is diabetic,
If the patient is diabetic, he is more prone to pancreatic carcinoma, sir.
No, sir is asking if he is diabetic, what will happen to his diabetic status on developing CA head of pancreas? What could happen? That is what sir is asking.
Sir, he might develop hypoglycemia.
No, worsening of the diabetes,
Worsening.
not hypoglycemia. Okay. And so what would be the probable diagnosis here?
Sir, here, as the patient is complaining of loss of weight primarily with anorexia and jaundice associated, I'm associated with features of obstructive jaundice. I'm thinking some malignancy related to either, if we think of benign reason, can be, sir, choledocholithiasis, or it can be Merizi syndrome, sir.
No, you have to tell the differential diagnosis in the order of your importance. So is that common?
You're not gone to the clinical examination. With the history wise, we are asking.
Yes, sir.
You are not supposed to diagnose Merizi syndrome on clinical exam.
Yeah. That is.
It is a radiological diagnosis. Merizi is never uttered in the examination. It's only the radiological examination, radiological diagnosis.
Yes, sir.
He said it's a malignant obstructive jaundice. Why did he say benign cause? Now, probably what benign cause you have? What benign cause will have a loss of appetite, loss of weight? Is that significant loss of weight?
Yes, sir.
So, which benign lesions will have this kind of an history?
It can be choledocholithiasis, sir.
Choledocholithiasis will have loss of weight, anorexia.
Loss of weight will be not
significant jaundice. You mentioned itching.
Yes, sir.
Have you ever seen a CBD stones presenting with an itching and deep colored urine, whatever he said, high colored urine? No,
sir.
How do you differentiate clinically? How do you differentiate benign versus malignant obstructive jaundice?
So in malignancy, it can be a cholangiocarcinoma.
No.
Periampullary carcinoma.
My question is, how do you differentiate benign versus malignant obstructive jaundice? What are the causes of benign obstructive jaundice?
It can be a stricture in the CBD, sir.
Stone disease, commonly seen.
Stone disease can be.
So how do you rule out stone disease? They may have a pain in the abdomen, biliary pain.
Yes, sir.
They may have biliary pain. Don't say colic; it's misnomer. Biliary pain. And they may have cholangitis. Then there's no loss of weight and appetite. So you consider a stone disease. Any other benign diseases? You may have a loss of weight and appetite and still presents with an obstructive jaundice. Chronic pancreatitis and a stricture.
Yes, sir. CBD stricture and can be there, sir.
Not necessarily that you have to agree whatever I say. You can say why it's not chronic pancreatitis with an obstructive jaundice also. They'll have an history of exocrine endocrine deficiency. So that kind of history is not there. So unlikely at this stage. If they have an history of diabetes or history of exocrine insufficiency with typical pancreatic pain, you may consider a benign pathology. But this patient does not have that kind of a pain.
Yes, sir.
So unlikely.
Yes, sir.
Yeah. Yes, sir.
Pain is also not relating to back, sir. So features of chronic pancreatitis unlikely. No episodes of similar pain in the past, sir.
So a lady, non-alcoholic, non-smoker. So that you can rule out.
Yes, sir.
So any other benign causes?
Whenever there is a history of previous surgery and then patient developing obstructive jaundice, what could be the possibility? Recent history.
Can be, sir, any outlet obstruction?
No. Recent surgery, following surgery, patient developing jaundice. Laparoscopic surgery. Very
Can
common.
be, yes, sir. Due to bleeding, sir, intraperitoneal bleeding.
Or could it be a benign biliary stricture like post-cholecystectomy? So that is
Yes, sir.
also one of the commoner causes of benign obstructive jaundice.
Yes, sir. Sir, how it will take some time to develop a stricture?
If it is completely clipped,
Yes, sir.
Polyductal cyst
Polyductal cyst can present.
can present with biliary, obstructive jaundice.
Yes, sir. At times it can present.
But how do you rule out? By history-wise.
Sir, usually polyductal cyst will be, the history will be long, sir.
Yeah.
It will not be a short history.
Okay.
Yes, sir.
Biliary pain, they may have complications like cholangitis, pain.
Yes, sir.
However, sometimes malignancy in the background of polyductal cyst cannot be ruled out at this stage.
Yes, sir.
Okay. Okay. Next, go to the examination.
General physical examination. Patient was examined in a well-lit room after obtaining verbal consent in the presence of a female attender. Patient was conscious, cooperative, well-oriented to time, place, and person. Moderately built and nourished. The BMI was 18.4 kg per meter square. There was no pallor, clubbing cyanosis, lymphadenopathy, or pedal edema, whereas icterus was present. There was hollowing of both left and right supraclavicular fossa. In the oral cavity, dental caries were present, and the mucous membrane was moist. Vitals: pulse rate 84 beats per minute in right radial artery, regular in rhythm, volume, and character. Blood pressure being 134 by 80 mm of hydragaram in right arm supine position. She was afebrile, respiratory rate being 16 per minute, and maintaining a saturation of 100% in room air.
What do you expect in obstructive jaundice? Either heart rate or pulse rate?
Yes, sir.
What do you expect
you
heart
expect?
rate in an obstructive jaundice? What happens to the heart rate?
Will be the pulse rate.
Usually, sir, tachycardia could be there due to cholangitis, sir, associated cholangitis.
The patient has cholangitis, well, they may have. In absence of cholangitis, this patient does not have cholangitis.
Yes, sir. Due to pain, the patient might have tachycardia.
No, something gets deposited in the essay note. Jailal sir is laughing. Sir,
I'll tell you, you'll have bradycardia.
Otherwise, this
the
question
bile
would have
salts
been
in the
asked.
essay note.
Something that is very particular. That is why the question is asked.
Deposition of the bile salts in the essay note. That's why you're going for bradycardia. Santosh, correct?
Sir, what we expect in absence of cholangitis is bradycardia.
And there is a direct
Yes,
action of the bilirubin on the essay node also.
Yes, sir.
And there is a vagal stimulation, they'll have bradycardia. There are various ways of bradycardia. It's not only the deposition or bile salts or bile pigments. So it's in a direct action and vagal innervation, bradycardia. They'll have bradycardia.
Okay, sir.
To read pathophysiology of the obstructive jaundice. Okay, what is the cause of an itching?
The deposit of bilirubin in the skin, sir.
Bilirubin or anything else? What happens? Just deposition. Just deposition will cause itching.
It causes activation of histamine, sir. Release of histamine.
Then
That is one pathway. What are the other pathways of itching in obstructive jaundice?
I don't know, sir.
Peripherally, they cause release of histamine, and centrally also there are changes in the neurotransmitters. Okay.
Yes, sir.
So in physical examination, you are supposed to mention about scratch marks also.
Yes, sir.
Usually these people present with scratch marks, sometimes they will have abrasions and bleeding also in the abdomen particularly.
Okay, sir.
Fine, go ahead.
Per abdominal examination, inspection, the patient was adequately exposed and examined in the supine position. Abdomen appears flat with umbilicus centrally present and inverted. The skin over the abdomen appears normal. All quadrants moved equally with respiration. Stretch marks noted over the lower abdomen. No engorged veins. Visible pulsations or peristalsis noted over the abdomen. All hernial orifice appear intact and external genitalia appear to be normal. Palpation. All inspectory findings were confirmed on palpation. No tenderness was present. No local rise of temperature was present. A single palpable mass was noted in the right hypochondriac region, approximately 6 into 4 centimeters, globular in shape, hard in consistency, with irregular surface, margins extending 2 centimeter medial and 6 centimeter lateral to the right mid-clavicular line, and extending 5 centimeter inferior to the subcostal margin. The mass moved craniocaudally with respiration. There was no side-to-side mobility present. Plane of the swelling being intra-abdominal and intraperitoneal. On deep inspiration, liver was just palpable. Spleen was not palpable. On percussion, liver dullness noted from 5th intercostal space in the right mid-clavicular line till 2 centimeter below the right costal margin. Liver span being 10 centimeter. Dull note on percussion over the mass, which was continuous with liver dullness. No signs of free fluid was present. Rest of the abdomen was resonant. On auscultation, normal bowel sounds were heard. On per rectal examination, clay color stool staining was present. No blood or growth was noted. Summary. A 55-year-old lady presented with complaints of loss of weight since 3 months, dull aching pain, mostly in the right upper abdomen, over 1 month, aggravated after meals with progressive jaundice for 15 days, passing clay-colored stools for 10 days, loss of appetite for 1 week associated with generalized itching. Examination revealed a hard globular intraperitoneal mass with irregular surface of size 6 into 4 centimeter in the right hypochondriac region at the lower border of the liver, which moved craniocaudally with respiration.
Is it an Is it a gallbladder mass or
yes, sir. It was a gallbladder mass, sir.
It's not a distended gallbladder.
Not a distended gallbladder, sir.
Okay. What's your diagnosis?
Sir, my diagnosis will be obstructive jaundice secondary to carcinoma gallbladder, sir.
Okay.
How did you measure the liver span in this patient?
Sir, we start percussion from the 4th intercostal space, sir, in the right mid-clavicular line, downwards.
How do you know the 4th intercostal space?
Sir, usually the nipple will be in the 4th intercostal space, sir.
Nipple may be in a pendulous breast, that will go in the 6th or 7th intercostal
yes,
space.
sir. Yes, sir.
So
we will start counting from the 2nd intercostal space, sir, from above downwards.
How will you know where is the 2nd intercostal space?
So the angle of Lewis will be there, sir, at the sternal angle, sir.
Right. So you may start from there, but in this patient, there was a gallbladder lump which was there in the mid-clavicular line, is it?
Yes,
so
sir.
Measure the liver span in the mid-clavicular line.
Yes, sir.
You understand my question? There is a gallbladder lump which is there in the mid-clavicular line.
Yes, sir.
You are telling 10 centimeter liver span in the mid-clavicular line.
Yes, sir. Like at the adjacent to the mass, sir, I measured, sir, it was around 10 centimeter. But at the present, where the mass was present, there I didn't see the span of liver, sir. It was measured adjacent to it, sir.
So if there is a lump which is there in that area, in the gallbladder lump, especially if it is there, then you have to move your liver span laterally, and you have
Yes,
to
sir.
move at the anterior axis line there. Okay.
Yes.
Instead of having the mid-clavicular line, you will go to the anterior axillary line, and then there you measure the liver span. What is the normal liver span in the anterior axillary line?
Around 14 to 15 centimeters.
It's around 11 to 13 centimeters. 9 to 11 in the mid-clavicular line and 11 to 13 centimeters in the anterior axillary line.
Yes, sir.
And it will increase if you go to the mid-axillary line.
Yes, sir.
Dr. Arun, can we go to the inspection slide once?
Yes, sir.
Yeah. You just told that external genitalia appeared normal.
Yes, sir.
What's the importance of this specific sentence which you have mentioned?
Sir, usually in the female patients, we'll look for, as she was an elderly female, sir, we'll look for any vaginal prolapse is there or not, sir.
So that patient would have told, there can be several problems which a lady can. So is it related to your case or not? That is what is my
no,
question.
sir, just routinely done, sir.
Because there's something which is actually misinterpreted. The reason is why external genitalia is important in men. You tell me first. In abdominal mass, I'll put it that way.
Yes, sir. Sir, in men, usually testicular teratomas will be there, sir. If any testis is not palpable.
Don't jump and conclude testicular teratoma, usually there and all. No. What we would like to tell is epigastric large mass.
Yes, sir.
Young patient will come. So you may have to suspect probably a paralytic nodes. So you say examination of genitalia refer to testicular tumors. Please keep that in mind. Or suppose there's a renal cell carcinoma on the left side. What do you expect?
Yes, sir. Usually the testicular vein will be draining there, sir.
So
there can be metastasis to the right kidney, sir.
So you can only mention that I have examined for any hernial orifices. That is one important thing you should. Unless there is something which is lower abdominal mass, yes, there is a compression on the iliac veins, etc., may cause some varicosity, etc. Otherwise, this is not all that important. Okay, go to that. Did you mention supraclavicular region, rectal examination, pervaginal examination in this patient?
Sir, yes, sir. Rectal examination is done, sir. There was clay color stool staining present, sir. No blood or growth was noted, sir.
Yeah, but I didn't see any mention about supraclavicular region specifically.
Sir, in inspection, there was swallowing of.
No. Often, don't expect everyone to have a big supraclavicular node. Okay.
Yes, sir.
Patient has lost significant weight, so there's nothing unusual to find a supraclavicular region, empty ureter hole or something. But you need to mention it's otherwise it is incomplete.
Yes,
you understand? You have only done inspection, hollowness, but palpation wise later you have to mention.
I had confirmed with palpation, sir.
Arun, by the way, what is external genitalia in a female? We're discussing about external genitalia in the female. What is that?
Yes, sir.
Yes.
So, external genitalia comprises of the structures in the perineum, sir. Not proper, the vulva, the urethral orifice, the anal orifice, the
no, external genitalia in the female is the labia, you know?
Labia, sir. Yes, sir.
Right, which will have the minora, which will have the mesora, which will have the vestibule.
Yes, sir.
Okay. So uterus, if there is a prolapse uterus is there, that is not the external genitalia. So external genitalia is only the vulva is there, which has got so many other components which are there, mesora, minora, vestibule, and all those things. Okay.
Yes, sir.
And usually it is not good to say in a female patient that external genitalia is normal. Okay.
Yes.
As Dr. Shinoy was telling that, you know, it doesn't look nice to say that.
Yes.
That is okay. It's, in the male patient, it's okay that you have to tell that.
About sir, some of the examiners may take a bit, especially this sentence. Yes. Vaginal examination is very well accepted, but that is different than this inspection and all this external genitalia, as Dr. Khanna sir has told. Okay. Yes. So I think if it is probably it is not required. Okay.
Yes.
Dr. Arun, you got only one diagnosis, or you want to give any differential diagnosis?
Sir, Primarily, I would like to say, sir, carcinoma gallbladder.
Okay, what are the factors favoring the carcinoma gallbladder? From
Sir, the gallbladder
inspection.
is palpable, sir. The patient is having jaundice, obstructive jaundice, and as per Sir Courvoisier's law, in a patient of jaundice, if the gallbladder is palpable, it is said probably not due to stone, sir.
Gallbladder mass, why do you want to bring Courvoisier's law here to make a diagnosis of the carcinoma gallbladder? Is it common
yes, sir,
for
not required. Usually for periampullary carcinoma, we'll think of Courvoisier's law, sir.
No, with this clinical finding, if you make a diagnosis of gallbladder carcinoma, that means we know the diagnosis and coming out. It's not probably the first diagnosis we make. The patient has no ascites, patient has no other problem. Just there is the mass is there.
Yes, sir. The mass is hard to palpate, sir. With globular kind of mass, which is hard to palpate.
It is producing obstructive jaundice.
Yes, sir.
Why it is gallbladder mass is producing obstruction?
Sir, it can produce if supposedly if I think of gallbladder cancer, sir, so it can go to the lymph nodes. The portal lymph nodes might compress on the CBD, sir. So it can cause obstruction and cause obstructive jaundice.
There's only one reason, or you have other reasons too?
Other reasons are there, sir.
What are the reasons?
The direct invasion from the gallbladder can be there, sir. There can be other reasons like periampullary carcinoma, sir.
No. Carcinoma gallbladder.
Yes, sir. Sir, usually, usually the most common location will be, sir, fundus. So in that case, if the patient presents with jaundice, then usually it is a delayed presentation, sir. As the metastasis has already happened to the lymph nodes, sir, portal lymph nodes, compressing upon the CBD. But if it is in the neck of the
like a mass. When you have a tensed gallbladder, when there is very tense, it will also look like a mass only.
Yes, sir. But the surface will be soft to soft cystic, sir. Here it is not soft cystic. It is hard and the surface is irregular, sir. So I'm thinking of
mass arising from the liver.
Yeah. Why not? It's a liver lesion.
Considering the shape, sir, I thought of gallbladder.
Very good.
Anatomical.
Fine. What else? Can liver mass present with an obstructive jaundice?
It can produce, sir. But it should, with metastasis, should be there, sir.
One is metastasis.
Yes, sir.
Then,
sir, cholangiocarcinoma can produce.
No. I'm talking about liver.
Liver, sir.
Yeah. Liver mass, liver
Yes,
tumor, HCC. Okay. It can rupture the biliary tract and can have obstructive jaundice.
Yes, sir.
And direct extension into the porta.
Yes, sir.
Can have an obstructive jaundice. So why not this is in a liver mass? Simple. The question is, why not this is in a liver mass? One, you said shape, because of the gallbladder shape, you consider it in a gallbladder malignancy.
Yes, sir.
Number one. Number two, anything else?
The span of the liver is not that large, sir. Second thing.
Okay.
Could it be a carcinoma head of pancreas with liver mets?
It can be, sir. But liver mets in history wise, sir, like on palpations of the liver, even the border was smooth, sir, and the span is not increased. So less likely, sir.
Okay.
But
so that is why when you say the diagnosis, it could be like with this, at least it should be a differential diagnosis with weightage coming first and second. So
Dr. Arun, when you are asked
from saying it is malignant obstructive jaundice.
Hello, sir.
Yeah, when how to differentiate whether it's not a nodule in the liver versus a gallbladder. And as one question has been asked, why not a large secondary, one single big hard?
So the first of all, the site of the swelling, sir. at the lower border of the liver. Secondly,
And-
sir, mobility usually in the gallbladder, sir, side to side mobility will be there, sir.
Probably if this question is asked, it may be difficult, but what probably answer I expect is, sir, I trace the lower border of the liver.
Yes, sir.
From the right side, you start tracing, and this probably to consistency as well as borders are different. You mentioned,
Yes,
no, this is very
yes,
hard
sir.
and irregular. That's what you
Yes,
mentioned.
sir. And it is different from the feel is different from that of the liver, sir. The liver was soft, sir, to palpate.
No, don't say soft. Soft means it means a different thing. So,
Okay, sir.
Gallbladder is very deceived in palpation.
yes,
Like,
Yes, sir.
So how do you investigate this patient?
Sir, we'll go with first routine investigations like CBC, LFT. Primarily LFT, sir, is important here, which will confirm the diagnosis of obstructive jaundice, sir, with elevated liver enzymes, sir, elevated alkaline phosphatase, sir, and the conjugated hyperbilirubinemia will be there, sir. And next, we can go for radiological investigations, sir, like
What happens to SGOT, SGPT? You're not complete yet.
yes, sir. Sir, SGOT, SGPT can be mildly elevated, sir, but not that much, as it is not hepatocellular in origin, sir. If it is like not.
Okay. What else?
And GGT can be elevated, sir. Gamma glutamyl transferase.
Okay. What else?
And the prothrombin time and INR will be normal, sir, if liver is not involved.
Okay. You look for
And-
PTA, PTT.
And yes, sir. And
Then
albumin and globulin we should look for, sir.
total proteins, albumin.
Total protein.
So synthetic function.
Yes, sir.
So
Synthetic.
that completes the liver function test.
Yes, sir.
Okay. Yeah. What next?
Followed by we should go for USG scan, sir.
I will go for urea creatinine.
Yes, sir. After the yes, sir. Urea creatinine. Then
Why
just
it is important? Now I am coming back to the first question one. Why it's important urea creatinine?
Sir, it is metabolized in the liver, sir. To
What is metabolized in the liver?
urea, sir. Urea is formed in the liver from ammonia, sir. So the function of the liver we can get to know, sir.
Sorry, obstructive jaundice. What is relation of urea creatinine? It will be raised or not normal?
Don't know, sir.
Usually
it will not be raised, sir. Usually.
I'm not worried about the ammonia. I'm worried about the urea kidney function.
Yes, sir.
What happens in obstructive jaundice kidney function? This is very, very important. That's the reason why. Yeah, that's the reason why we prepare these patients before taking up for any intervention.
Yes, sir. There can be deposition of bile salts in the tubules of the kidney, sir, leading to elevated creat. It can be there, sir. Can lead to hepatorenal syndrome, sir.
Important, no? These are all
Yes,
important. Okay, so we do an urea creatinine.
Yes, sir.
The urea is high or creatinine is high. We definitely hydrate him.
Yes,
okay,
sir.
and yeah, again some more.
We'll get other routine investigations like chest X-ray. We'll get it done. PT-INR is done, sir.
Okay.
Yes, sir.
Can it be deranged? PT-INR, can it be deranged?
Yes, sir.
Can PT-INR be deranged in this patient?
Sir, in this patient, it is less likely, but if the hepatocellular function is compromised, sir, PT-INR will be deranged.
Why not? Why if the hepatocellular function is good? Do you mean to say there will not be a deranged PT-HPT?
It can be there, sir, but less likely.
How?
Due to obstruction, there will be, sir, in dilatation of the intrahepatic biliary tree, and the function of the due to obstruction, the function of the liver will be compromised in later stage, sir.
Dr. Arun, which vitamin is necessary for coagulation factors synthesis?
So vitamin K, sir.
And does it depend on biliary synthesis? Like bile is required for its absorption or not?
It's needed, sir.
So without even hepatocellular dysfunction, obstructive jaundice can cause vitamin K deficiency and subsequently derangement of PTNR.
Yes, sir.
PT measures the intrinsic factor or extrinsic factor?
Extrinsic factor, sir.
What do you mean by extrinsic factor?
Sir, factor 2, 7, 8, and 9 are synthesized by vitamin K, sir.
9 and 10.
9, 10, sir. Yes, sir.
What else? What other investigations?
Sir, we'll after the blood investigations, we'll get USG done, sir.
What is the idea of ultrasound? USG?
Sir, in USG, we will first look at the organ of origin, sir. Like what we are suspecting.
It's gallbladder mass.
Yes, sir.
So
We'll
what
confirm
do
the
you-
organ of origin, sir.
Okay.
And then in the gallbladder, we'll look for the wall, sir, the wall thickness. Then,
What does it matter? All thickness.
sir, usually in cases of malignancy, there will be calcifications and thickness will be more than around 4 to 5 mm, sir.
No, don't mix up 2, 3 things. One is said calcification.
Yes, sir.
Invariably, routinely you find calcification.
Routinely, we don't find, sir.
I've seen only 3 cases, 2, 3 cases of calcification.
Yes, sir. We can look for gallstones, sir.
Okay, one you said gallstones. Second,
Thickness of the wall, sir.
how much thickness is significant?
So more than 4 to 5 mm is significant, sir.
More than 3 mm.
Yes, sir.
When do you consider malignancy?
More than 4 mm, sir.
1 centimeter.
Yes, sir.
Okay. What else? What
Then
else?
we'll look for, sir, any presence of ascites and presence of mets in the liver or omental mets, sir. We'll look for
How good is ultrasound to detect the mental mets? It's not.
It is not that good, sir. But we can try.
Then why are you mentioning?
Yes, sir. Then lymph nodes we can look, sir.
Lymph nodes, okay. What else?
So you mentioned obstructive jaundice. What will you see in liver? What do you expect of ultrasound in the liver?
Sir, dilatation of the intrahepatic biliary tree, sir.
Okay, so that gives you an idea of whether only intrahepatic or extrahepatic biliary radicals are also dilated.
Yes, sir.
Okay, that will give you an idea. You can also see for liver metastasis.
Yes,
okay,
sir.
you can also see for any mass per se in gallbladder also. Okay.
Yes, sir.
What is the sensitivity of ultrasound in diagnosing gallbladder mass or malignancy?
So around 80% it is sensitive, sir.
Oh God. 80%, then you don't need CT MRI.
Sir, if it is showing signs of advanced disease, then we need not go for CT scan.
Only 40%.
Yes, sir.
Not more than that.
Okay, sir.
Okay, fine. Do you have ultrasound report here?
Yes, sir. Ultrasonography, the gallbladder measures 8 cm in length and 4 cm in width with diffuse circumferential wall thickening, measuring 6 mm, showing increased vascularity on color Doppler flow. Imaging measuring 16 mm at maximum thickness is noted, involving gallbladder with a 11 into 8 mm size calculus. Noted at the fundus, a relatively irregular hypoechoic lesion measuring 59 into 47 mm, showing vascularity on color Doppler. Noted in adjacent segments 4 and 5 of the liver, causing mass effect in the form of dilatation of the intrahepatic biliary tree. Few enlarged perihilar and peripancreatic lymph nodes are noted, largest measuring 25 into 19 mm in the perihilar region. Features are suggesting of carcinoma gallbladder with invasion into the liver.
Okay. What could be the carcinoma gallbladder?
Yes, sir.
Your diagnosis is confirmed.
Yes, sir.
You want to do biopsy?
Sir, biopsy we should do only in inoperable cases, sir. Usually we will not go for biopsy, sir.
Do you think this is an operable lesion?
Sir, for that we should get CT scan done for staging of the.
So what is your staging on a sonography?
Staging, sir, depending upon the up to what extent it has involved.
You have findings here.
Yes, sir.
You have findings here.
Yes, sir.
What is what to be the approximate staging?
Dr. Arun, there is a node, peripancreatic node, which is greater than 2 centimeters. And short
Yes,
axis is 19 mm.
19 mm, sir.
So just answer Dr. Veerappa, like what is the...
It is
You answer
N1,
to
sir.
Dr. Veerappa.
It is usually a stage 3, sir.
What do you mean by stage 3?
So stage 3 can be T1 to T3 with N1 and N0, sir.
What about the liver lesions? You said this. Yeah, please.
Histology of the gallbladder wall and the stomach.
Yes, sir. Please repeat.
If there is any difference in the histology of the gallbladder wall or intestinal wall?
Yes, sir. In the gallbladder wall, usually there will be no submucosa, sir. And in the intestine, submucosa will be there. And there will be single layer of muscle in the gallbladder, whereas in intestine, we get 2 layers of muscle, sir.
So which muscular layer is absent? What are
Sir,
the 3 layers of mucosa?
Yes, sir.
What are the 3 layers of mucosa?
Sir, lamina propria, musculus mucosae,
And lining epithelium. So which is absent in this gallbladder?
So the muscularis is absent, sir.
Muscularis mucosa is absent and submucosa is absent.
Yes,
so what
sir.
comes next to lamina propria is directly muscularis propria.
Yes, sir.
Very significant. That is why it's very quickly you can start. It goes for the fixation and infiltration to the adjacent structures.
Yes, sir.
Now, can you tell me what could be the reason for an obstructive jaundice here?
So the reason for obstructive jaundice could be compression of the CBD, sir.
By the?
At what level? At what level?
At the peripancreatic area, sir. In the ampulla, near the ampulla, sir.
No. Why near the ampulla? You can see in the perihilar region, there's a largest node measuring 25 to 19 millimeter.
Yes, sir.
Why not that is compressing at the hilum, causing an obstructive jaundice?
It can cause, sir. Yes.
Not at the ampulla. Ampulla is too far away.
In this case, yes, sir.
Okay. So what next? What do you want to do?
We can go for staging, sir. Means next we can go for CCT, sir.
I don't know how to stage. Please, you want to do?
But in USG, if it is very clear, sir, if we are very clear about stage, sometimes we need not also do staging, sir. We can go for surgery, sir.
You want to do surgery? Or you want to go for a CT scan here? The reason why we are asking all these questions are there are many lymph nodes around the gallbladder. At the hilum, very pancreatic lymph nodes are present. And also there is a lesion in the segment 4 and 5 also.
Yes, sir. It's better to go for CT scan, sir.
Okay, fine. Go ahead. We'll do CT scan. But before that, you would like to hydrate the patient?
Yes, sir.
He may have renal dysfunction.
Dehydration, sir. So
we need to see the creatinine and then go for a contrast.
Then we go for CCT, sir.
Very good. Okay, show me. Yeah, read. Okay.
Sir, here conglomeration of multiple calculi is noted within the gallbladder, together measuring 15 into 11 mm. Largest individual calculus measuring 4 mm, suggestive of cholelithiasis.
Why they're mentioning the size of the stone in the ultrasound and CT scan? Why can't they say simple stones are present?
So
is there any relation between the size of the stone and the gallbladder malignancy?
Single large stone is a precursor, sir.
Large means what large? How much large is large?
How large?
More than 2.5 to 3 centimeters. Sir.
How frequently you see such a big stone?
Less frequently, sir.
Okay. The role of 1 centimeter, more than 1 centimeter, a stone, more than 1 centimeter polyp, 1 centimeter thickness of the gallbladder wall. These are all the things which helps in diagnosing a malignancy, gallbladder malignancy. Yeah.
Yes,
Okay. Go ahead.
Gallbladder walls are poorly visualized. These appears to be 6.2 mm size suspicious rent at the fundus of gallbladder, with evidence of a large hypodense peri-gallbladder 63 into 59 mm size lesion. Moderate bilobar intrahepatic biliary radical dilatation noted with focal abrupt narrowing distal to porta hepatis, raising suspicion for stricture CBD.
So is it right to use this word rent, suspicious rent? Okay,
Some
fine.
focal involvement of the gallbladder they want to mention.
Okay. So is there anything else mentioned in CT?
CT, sir, we got done, but it was suggestive of mostly of inflammatory lesions, sir.
No, CT. Anything else did they mention in CT?
No, sir.
Is that all the report? Like even in ultrasound, you mentioned more about lymph node
Yes,
and all
sir.
here. I'm not seeing much about lymph node, about liver, about ascites.
Yes, sir. CT scan, sir, only it was showing as an inflammatory swelling, sir, and they got it done not at our center, sir. They got it done in some discount outside.
Okay, forget about all those things. What else do you expect in a carcinoma gallbladder?
We will expect the involvement of lymph nodes, sir.
Other than these findings, they mentioned lymph nodes also.
Yes, sir.
Other than this, what else do you expect?
Any mets we should look for that, sir.
Any metastasis?
Any umbilical, any secondaries in the liver.
Okay.
Any peritoneal mets, sir.
Okay.
And omental mets, as before I mentioned.
Ascites. Would like to know whether it's ascites or not.
Yes, sir. Ascites. We should see.
Okay. So what next now? We are fairly sure that it could be it's in a carcinoma gallbladder with a lymph nodal involvement.
Yes, sir.
And nodes compressing at the hila, causing an obstructive jaundice.
Yes, sir.
So how shall we proceed now?
Sir, after this CT, ideally we should go for surgery, sir.
Directly with such a high bilirubin?
No, sir. Before we should prepare the patient for surgery. We should lower down the jaundice by doing ERCP, sir. ERCP and stenting of the CBD.
Not ERCP. ERCP is to know you'll injecting the contrast and know the biliary tract. We know that there's an obstructive jaundice.
Yes,
so we don't want any diagnostic procedures here. Already done. CT has been done. Ultrasound has been done. So if you want to stent and decrease the bilirubin, that's fine. So endoscopic stenting. That's what you mean. Not ERCP.
What was the bilirubin level?
So the bilirubin level was 8.3, sir, before ERCP. Total, sir.
Now, do you think 8.3 with the CT finding or going to think it's a malignancy? CT is not showing any evidence of node. It only says
yes,
there is an inflammation. And bilirubin is only 8.
Yes, sir.
Now, how do you want to put the diagnosis as a carcinoma? Ultrasound, fine. It has given a node. But this CT is not mentioning about the node. It is not saying anything about the mass.
Yes, sir.
It looks like an inflammatory mass with the bilirubin 8.
Yes, sir.
Normally, with the bilirubin 8, putting it in a malignancy side is little on the bizarre, unusual side.
Yes, sir. As the history is, there is short history, sir. I feel we can think.
You said it is a painful jaundice. It could be the past. There is a stone is there.
Yes, sir. To confirm, sir,
you done any other thing further to see? So USG and CT, there is a contrast. Very, very different views are there. Did you do any other investigation, or straight away you are thinking of a malignancy and going ahead?
We should go for diagnostic lab, sir.
Have you done? I'm asking you.
No, sir, we had not done, sir.
It's okay. Suppose, as Dr. Jailal said, why not? It's an inflammatory lesion. So, what kind of inflammations will have this kind of picture?
Cholangitis can be there, sir.
No, no, no. Do you know xanthogranulomatous cholecystitis? Have you
Can
heard
be
of
gallbladder.
I've heard, sir, but I have not read about it.
Fine, it's okay. So sometimes xanthogranulomatous cholecystitis can mimic malignancy. They can have pericholecystic fluid and nodes also around. So you should be able to differentiate these two. Difficult to differentiate sometimes. Okay,
Yes,
fine. So what do you want to do? See, surgery, you've been saying surgery. Surgery is not the answer in any, if you are suspecting carcinoma gallbladder,
yes,
with
sir.
the nodes around the porta and with an extension into the liver, it's not easy to do a surgery for carcinoma gallbladder here. And his bilirubin is 8. Any surgery related to the liver, you want to do a liver resection, the bilirubin should be less than 3, less than 2 in fact. Less than 2 in fact. So periampullary obstructive jaundice is something different. Gallbladder malignancy causing obstructive jaundice is something different. There with 10 bilirubin also can operate periampullary, but not here. We need to bring it down. You said endoscopic stenting. Has it been done in this patient?
It's done, sir.
Okay. So what was the bilirubin after that?
Post stenting, sir, bilirubin came down to 2.8, sir.
Very good.
Totally.
So you must mention that. So
Yes, sir.
endoscopic stenting as a part of the preparation for a surgery, if you are planning,
Yes,
for contemplating for a surgery.
Yes, sir.
Okay. Is there role for tumor markers?
Yes, sir. We should get CA 19.9 done, sir.
19.9, 19-9.
19-9.
What else?
CEA, sir.
So both have been done.
Yes, sir.
So
They are under normal, sir.
how does this going to useful in carcinoma gallbladder?
Sir, if the CA 19-9 is markedly elevated more than 50 or 100, so we can, it is mostly an advanced disease, sir.
Okay. 1.
So operability is less, sir, in these cases.
Okay.
What's the normal value of CA99 up to?
Up to 37, sir. Unit per milliliter.
Okay. So what else will you see in carcinoma gallbladder patient and CT? Like it is not given, but what do you expect? What you are expected to see?
So apart, we'll see the lymph node, the ascites, the secondaries in the liver, sir.
So like no, whenever it causes jaundice, when you are contemplating for a liver resection, you should see for the involvement of the
left
artery
and
and
right.
vein.
Yes, sir.
Artery and vein also. Okay. So if you are planning for an extended resection, then you have to look for a future liver remnant also.
Yes, sir.
Okay.
Future liver remnant.
What is laparoscopy in the patient?
Yes, sir.
What is the role of diagnostic or staging laparoscopy in this patient? What is staging laparoscopy?
Sir, staging laparoscopy is done to usually stage the disease, sir. To usually know, like, and we can take biopsies and we can know whether it is, what stage it is, whether it is an advanced disease.
This patient with suspected carcinoma gallbladder in staging laparoscopy, what all things you can do?
We can take the aortocaval lymph nodes, sir. We can do the biopsy. We can send for biopsy. It is positive. If it is positive, then we should not take the patient for surgery.
So it is considered as
advanced
B1.
disease.
Okay.
Yes, sir. 16B1, sir.
M1 disease.
So,
the celiac group of lymph nodes are present?
Yes, sir.
The celiac group of lymph nodes present?
Celiac group of lymph nodes, yes, sir. Station 9, sir.
Now, if they are present, you still go ahead with a resection, or is?
We can go ahead, sir, with extended radical cholecystectomy.
No. Celiac group of lymph nodes, parietic, paracaval, they're all M1 disease.
Yes, sir.
Okay.
Okay.
So what surgery has been done here?
Sir, here we planned for radical cholecystectomy. But after opening the abdomen, sir, right subcostal incision was given. There was marked adhesions from the gallbladder mass to the duodenum, sir. And considering the age and factors, sir, we just took biopsy from the gallbladder and closed it.
Okay. It's basically an advanced disease because
Yes,
lymph nodes are there and it's beyond T3. So it's a T4 disease.
yes, sir.
So chances of resectability is less. So diagnostic laparoscopy or just biopsy the lesion is enough to go up for an chemotherapy.
Yes, sir.
And of course, metallic stent to relieve the jaundice.
Yes, sir.
So what is the biopsy report?
Sir, biopsy report came to be gallbladder adenocarcinoma, which is moderately differentiated, configuration being diffusely infiltrating, and microscopically it was invading till the serosa, and lymphovascular extension was present. So T3 and is given, sir.
But how do you know that it's N0? There's so many nodes are there.
Sir, actually, we for HPR we had not sent so the nodes. So
we do not know the status. So we do not
Yes,
know.
sir.
We cannot put it as N0.
You cannot
NX,
say
sir.
T3. You can just say diffusely infiltrating, moderately differentiated adenocarcinoma, and that's it.
Okay, sir.
So what are the prognostic factors in carcinoma gallbladder?
Usually, sir, in this stage, it has a poor prognosis, sir.
No. What are the prognostic factors?
Prognostic factors being according to stage, sir. If the invasion is, if there are presence of metastasis, ascites, and so
Stage,
we
end stage, like this, you can say T stage, end stage, metastasis, and what else? What are the prognostic factors?
consider the
Present-
age of the patient.
For example, T1 disease have better prognosis compared to T3, T4.
Yes, sir.
Like that. Yeah. Then one.
N0.
Yeah.
N0 has better prognosis, sir.
Yeah. Then
If there is
how
no
many
metastasis.
How many lymph nodes? You know,
N1.
AJCC. You know, AJCC.
Yes, sir.
Yeah, please go ahead.
Yes, sir. In according to AJCC classifications of TNM staging, T1 is classified into T1A and T1B, sir. T1A is a tumor invading the lamina propria up to the lamina propria. T1B is tumor invading up to the muscularis propria, sir. T2 is further classified into T2A and T2B, sir. T2A is tumor invading the perimuscular connective tissue at the peritoneal side, but not involving the serosa. And T2B is a tumor invading the perimuscular connective tissue at the hepatic side, but not involving the serosa. T3 is a tumor invading or perforating the serosa and invading into the liver or adjacent structures, like liver. And T4 lesion is a tumor extension to the portal vein, hepatic artery, and two or more adjacent organs. Coming to N, sir. N0 is not involvement of nodes, sir. N1 is involvement of 1 to 3 lymph nodes. N2 is involvement of more than 3 lymph nodes, sir. If metastasis is present, it is M1. If it is not present, it is N0, sir. Again, we classify according to stages, sir. So stage 1 is T1, sir. Stage 2 is T2. 2A is stage 2A is T2A. Stage 2B is T2B. Stage 3 is 3A and 3B, sir. And 3A is T3, sir, N0, M0. 3B is T1 to 3, any T, with N1 is 3B, sir. Stage 4 is again classified into 4A and 4B, sir. 4A is, sir, any T which is with N2, but metastasis won't be there, N will be 0, sir. And in 4B, it is anytime M1, sir. The metastasis will be present.
Okay. What is incidental carcinoma gallbladder?
Sir, the patient will not have any symptoms or signs. Incidentally, on if we find that the incidental finding on usually on a USG scan. So
No.
You have done laparoscopic cholecystectomy or sent gallbladder for biopsy, and that comes as a malignancy. That is incidental.
Yes. T1A can be there, sir.
Not necessarily. Not necessarily T1A. It may be T2 also. Most of the times it's T2.
T2.
Okay.
Yeah. Any questions?
What do you do further, sir, if you do an incidental carcinoma? Sir, Birappa,
Sir.
If you get an incidental carcinoma, what will be the further plan of management?
Sir, if a case is referred after laparoscopic cholecystectomy and the biopsy report is a malignancy, definitely I would like to T-stage the disease and do a CT scan. Rule out any other metastasis, lymph nodal metastasis. And if it is beyond T2B, we go ahead with an hepatoduodenal ligament radical lymph nodal dissection, lymphatics, as well as excision of segment 4B and 5. There is a role for an PET CT because CA gallbladders are PET avid tumors. There is a role if it is beyond T3. So that is our protocol, and surgery is done at the earliest. The best time would be less than 2 weeks with better results. This is our protocol, sir.
If it is stage 1A, you can keep it. No, sir.
Yeah, confined. If it's confined to mucosa, the cholecystectomy alone is sufficient. Any other
chemotherapy?
I had a few. Like we also the primary surgeon and asked for any bile spill and about cystic at also, sir.
Yeah, that's important. Bile spillage and gallbladder rupture is most important. Excision of the port site is not necessary. It's not going to improve the survival rates. We used to do initially we used to do that, but now we are not doing.
Post-state metastases are equal to systemic metastasis, sir.
Yeah.
It is done only leave pain in particular patients.
In this case, Santosh, what will be the follow-up? Chemotherapy or what?
So this will, as said, we can put a metal palliative and then put patient in most likely palliative chemotherapy. Patient may also get palliative stenting for, they may usually go in for duodenal obstruction also, such cases. So they may require a palliative gastric outlet stent also, in addition to the CBD stenting. And mostly it is gemcitabine based, sir.
Can I give sir send a message to close?
Yeah.
5 minutes.
Okay. Okay. Well, any doubts you have, Arun?
Yes, sir. I have one doubt, sir. Like I would like to know, sir, about primary sclerosing cholangitis associated with malignancy, sir. If you have any experience, sir.
I don't have any experience, but it's one of the pre-malignant lesions. There can be association of CA gallbladder with sclerosing cholangitis. I have not seen any case of carcinoma gallbladder with sclerosing cholangitis.
It's rare, sir.
Yeah. I don't know about other faculty experience. I have not seen. Polyps we have seen. Polyps, thinking that's benign, and we have sent for malignancy on the table, frozen on the table, and turned out to be malignancy.
Yes, sir.
That's why more than 1 centimeter polyps needs to be excised, especially in endemic area in India, South India especially.
So less than 1 centimeter polyps also we should send for biopsy or?
All polyps definitely need to send for biopsy.
Yes, sir.
But less than 1 centimeter polyp, usually we don't advocate for cholecystectomy. We just keep them.
Yes.
Okay, sir.
Dr. Arun Pandey, in a later note, since you said whether should we send polyp for biopsy, you should remember my professors used to tell, except a nail and hair, everything else in the body should be sent for biopsy.
Yes, sir.
No, this is a very important thing. You may think sometimes a sebaceous cyst, it has happened. They did not send the wall. It turned to sebaceous carcinoma. So I'm just trying to tell you So it should be an important thing. Whatever you take, whether you may think fat or momentum, or lymph node, whatever it is, it has to go for a biopsy.
Yes, sir.
Dr. Birappa, one things for you, and probably they say talk lots of carcinoma gallbladder in North Indian thing, no?
Yes, sir. Yes, sir.
So that what is the main etiology? What they say? I think Dr. Karna survey also may be able to join here now. What is
Karna will be able to say that?
Yes.
Probably because of toxins all along the Ganges. So, and stone disease, more common in stone disease is more common in North India. Of course, South India also we have been seeing a lot of stone disease.
In one or two, obviously I have not done any radical cholecystectomy, but I have found suddenly some kind of a surge here also. Males having a gallstone, thick wall. You mentioned, no, that 1 centimeter and all, you know.
Yeah.
And many have turned out to be positive. Luckily, some are mucosal lesions only, but some are invading. So that's just observations. That's all.
I think the main reason is stones. Stone disease is more common in North India, so than South. So and associated some toxins like aflatoxins along the Ganges, and not exactly, but highest incidence in the country is Delhi, in the world.
Those was in Delhi.
Yeah.
Yes, sir.
You have a lot of incidents there.
It was very high, sir. As sir said, the Ganga belt, the all below the Himalayan region, sub-Himalayan belt, because of the mineral changes of the water which they consume, and as sir said, the stone disease, it was much more commoner. 60 to 80% of carcinoma gallbladder in India appear in the background of gallstones, whereas 3 to 5% of gallstones may develop into carcinoma gallbladder, sir. So any stone more than 1 centimeter which is present in the body for greater than 20 years, the risk of developing carcinoma gallbladder is very high. So that is also there. More than 1 centimeter, more than 20 years, the development of carcinoma gallbladder is very high.
Thank you, Sundar.
Yeah. Shall we go ahead to second case? Arun, is it okay?
Yes, sir.
Okay. Thank you, Arun.
Thank you so much, sir.
Thank you. We'll move on to next case.
Very sir.
Kanawal, sir.
Yes,
You can
sir,
unshare
yes, sir,
your
yes,
screen, Arun Pandey.
You have to unshare Dr. Arun Pandey.
Yes, sir.
Kedarnath, are you ready?
Yes, sir. Am I audible, sir?
No, wait. Let him answer.
Yes, sir.
No, still yours.
What is the question, sir? He did not understand.
No, Kedarnath. Arun Pandey, answer. The next boy will.
Okay, sir. Yes, sir. I'm sure.
Yeah. Okay, we'll move on to next case. Kedarnath,
Yes, sir.
are you ready? Yeah, please.
Yes, sir.
Share your slide.
Yes, sir.
Make it full screen, Kana.
Yes, sir.
Yeah, good luck, ma.
Yes, sir. Thank you, sir.
Start,
Sir.
Arun.
Good evening to one and all present here. I'm Dr. Kedarnath, MSPG, Department of General Surgery, Coimbatore Medical College. I would like to thank my Chief, Dr. Lakshmi Narayani ma'am, and my guide and professor, Dr. Srinivasan sir. So my case is a epigastric mass. A 39-year-old gentleman, Mr. Soundarajan, resident of Palni, belonging to low socioeconomic status, came to a general surgery OPD with complaints of mass in the abdomen for 2 months and recurrent pain in the upper abdomen for 2 months, complaints of multiple episodes of vomiting in the last 2 months. History of presenting illness, he was apparently normal 2 months back, after which he noticed a mass in the upper abdomen, incidence in onset, progressive in nature. Initially it was small, gradually increased in size to reach the current size. So complaints of abdomen pain on and off for a duration of past 2 months, diffuse, dull aching type, involving the upper abdomen and radiating to back. The pain is relieved partially on taking medication and by leaning forward. Complaints of multiple episodes of vomiting in the last 2 months, which was non-bilious and non-blood stain, 2 to 3 episodes per day on and off. History of early satiety plus was present. No history of abdominal distension, no history of fever, no history of trauma, no history of not passage of flatus by feces, no history of jaundice, no history of chest pain, no history of breathlessness, no history of significant weight loss. Past history, no history of any comorbidities, no history of any previous surgeries, history of similar episode in the past over the past 2 months, for which he was treated with medication in a private hospital, and details was not known. Personal history, he consumes alcohol for the past 20 years for about 180 ml per day. History of smoking BD occasionally for past 20 years. He has normal sleep pattern and normal bowel and bladder habits. Family history, no history of similar illness or malignancies in the family. I would like to summarize my history. A 37-year gentleman with complaints of abdominal pain and mass in the abdomen for 2 months, associated with vomiting with early satiety, and a history of chronic alcoholism. Shall I go to general examination, sir?
Yeah, please. Can you go back to the previous history? History slide. Okay, why did you ask history of trauma here? You asked specifically no history of trauma.
Sir, because I was holding maybe hematoma.
Mass in the abdomen. This is a mass in the upper abdomen, which is causing pain and vomiting.
Yes,
and why did you ask? This is causing pain and vomiting and early satiety.
Yes, sir.
Why did you ask history of trauma?
Sir, to rule out any trauma, I thought it was hematoma, sir.
Hematoma.
Hematoma of what?
Hematoma can be so big.
No, sir.
Hematoma can be so big.
No,
I
sir.
thought you have something in your mind. That's why you asked history of trauma.
Sir, blunt injury to the blunt injury of the abdomen will have a collection, sir. Pancreatic trauma can also give rise to such swelling, sir.
Okay, you wanted to rule out pancreatic trauma. Hematoma can cause vomiting and pain.
So if it is obstructing the stomach, it can cause vomiting.
Hematoma where?
Santosh, where is the hematoma? You are telling parietal wall hematoma or intra-abdominal hematoma?
Intra-abdominal.
Where? You said hematoma causing obstruction. Santosh asked you where you get the hematoma to cause obstruction.
Sir, maybe retroperitoneal hematoma, sir.
Can be in duodenum also.
Duodenal hematoma.
Hematoma causing early satiety.
No, sir.
Duodenal hematoma can cause vomiting.
Yes, sir. Yes, come on.
Anyhow, it's okay. So if you are thinking in terms of any solid organ injury following a trauma, that's fine. But don't say that hematoma will cause vomiting. Very rare. Duodenal hematoma can cause a vomiting, and it can subside slowly. You don't find such a big hematoma in the abdomen. Very rare. Okay. You ask some more history. History of no jaundice, no something. Can go to the next slide.
Go to the next slide.
Yeah. No history of abdominal distension, no history of not passing the flatus feces. No history of not passing flatus or feces.
What do you mean by that? Patient had constipation, obstipation?
Sir, I wanted to rule out Elias, sir, because he's also having a known case of alcoholic, sir. So
No,
he's
you mentioned as not passage of flatus and feces.
no, he's not having any low GI symptoms.
Mean to say patient does not have an intestinal obstruction.
Yes,
you could have no abdominal symptoms. You could have said just like that.
Yeah.
There's no negative history. Not this much.
Yeah, it's not necessary.
Elaborate.
Okay.
Any mention about GI bleed?
No, sir. No history of melena or no history of
Hematemesis. Okay, fine.
Why do you ask the history of melena?
Sir, upper GI bleeding, sir.
What is that upper GI means?
It is a It is a epigastric mass, sir.
What do you mean by upper
No,
GI?
sir. What is upper GI bleed?
Sir, upper GI is above the ligament of Treitz, sir. Bleeding from structure.
Where is that ligament and teres is there?
Sir,
Treats.
Ligament and treats where it's there.
second, it is attached from the diaphragm to the second part of duodenum, sir.
Is it the second part?
Yes, sir. Third part, sir.
That
Fourth
part.
part. Fourth part.
No, sir. Third part.
No. DJ flexion.
Twice we have given.
DJ flexion.
No.
No.
The DJ flexion. Okay. So this is why in one area I think most of the PGs are making some mistakes. When you say upper GI, you must know what is that. Can a lower GI produce melena? Lower GI bleed, can it produce melena?
Yes, sir. Yes, sir.
How? So whenever the transit time is more, it passes through, it goes for the bacterial oxidative reduction, and you can still get melena. When there is a bleeding is passing through a longer time, it is entering in the colon. But in general, we take the upper GI bleed. If the melena is there, we take as an upper GI bleed.
Okay.
Can upper GI bleed cause hematochezia?
No, sir. Lower GI bleeding will only cause hematochezia, sir. Active bleeding.
There is a massive bleed from the duodenum.
We do see
Don't say
cases,
absolutely no.
like sudden massive bleed causing a shock. Patient can pass fresh blood, though the bleeding is from duodenum. As sir said, duodenal ulcer, we have seen cases.
Yes. Aneurysms rupturing into the duodenum. They can have massive bleed. Okay. So you did not answer. Ligament of Treitz attached to?
DJ flexure, sir.
Very good. Fine. Go ahead. So what is your diagnosis based on history?
So based on these three, he has a similar episode in the past, sir. Probably acute pancreatitis, which is equally of acute.
Slow, Kedarnath.
Yes, sir.
No, you're doing well. You're doing well.
He gets
So,
tensed up. So
Stay calm. Answer. You're doing well.
So history of he is a known alcoholic with history of similar episode in the past, sir. So probably a sequelae of acute pancreatitis, maybe a cystic lesion arising from the pancreas, sir.
Probably sequela of acute pancreatitis.
Sequelae of acute pancreatitis, sir.
Okay. So could it be
Does history give any history of acute pancreatitis? Sorry
Yes,
to interrupt.
So yes, similar episodes in the past, sir. Similar episodes of abdominal pain following abdominal pain, which gets relieved on taking medication and leaning forward. And he has also been treated outside for the same conditions, sir.
Why a pancreatic pain relieved on leaning forward?
Sir, it's a as you lean forward, so retroperitoneal mass, lean forward, tension will reduce, sir.
No, what will happen when he is leaning forward and why there is a pain?
Sir, leaning forward, sir, pain radiating to back is mainly because of the dermatome involvement, sir. Retroperitoneal structures, same, which are the same having the dermatome.
Dermatome. No, this is another big. What is the dermatome you mean? Is it a skeletal nerve supplying pancreas?
No, sir.
Then why is a dermatome you are using the word? So it's a retroperitoneal structure. When the patient is leaning forward, the impression or the irritation it produced on the retroperitoneal structures will be less as it leans forward. Second, the stretching is also less with that when the C loop flexure.
What are the causes of pain in acute pancreatitis? What could be the reason for pain?
Inflammation of the pancreas, sir.
Inflammation of the pancreas. Okay. What happens if there is an inflammation?
Release of the pancreatic enzymes, sir. There will be it will increase of pancreatic enzyme and it will cause increase in secretion into the ductal obstruction, leading to increase in the interductal pressure, sir.
Okay. One is intraductal pressure.
Sir?
One is intraductal pressure, raise in intraductal pressure.
Rise in
Very
intraductal
good.
pressure.
Very good. One. We said release of the enzymes into surrounding structures.
Yes, sir.
Retroperitoneal nerves. What else? The gland will swell, no? What will happen?
Edema of the glands, generalized or focal edema of the glands, sir.
Parenchymal hypertension.
Yes, sir.
And peripancreatic fluid collections also. Okay. So what do you think sequela of the pancreatitis means here? I don't know exactly what is the sequela of the pancreatitis.
Sir, pseudocyst formation, sir.
Okay. What are the other sequelae of the pancreatitis?
Acute on it can be acute on chronic pancreatitis, sir.
Sequelae means what? Naturally.
Following an acute episode of pancreatitis.
One is the pseudocyst of the pancreas.
Sir?
You said one is a pseudocyst.
Okay, sir.
That is a sequelae of the pancreatitis. What else? Anything else? Or only when all the pancreatitis resolve into pseudocyst and then stops? That's what you mean to say.
What are all the fluid collections around pancreas? Is it only the pseudocyst or anything else? Anything else also?
So peripancreatic fluid collections will be present, sir. Then it will also release of enzyme. The pancreatic enzyme will also cause damage to the surrounding blood vessels. Sir. Blood vessels, most probably splenic artery, causing causing aneurysm, splenic artery aneurysm, sir. Then
okay. So to make it simple, the sequelae can be classified as fluid collections and adjacent organ damage. So please mention the other fluid collections which you know. Like you have mentioned acute peripancreatic fluid collection and pseudocyst.
Okay.
Any other fluid collections are also coined? Any set terminology is there for acute pancreatitis fluid collections? So there can be an acute necrotic collection and there can be a walled off pancreatic necrosis. So by definition, less than 4 weeks, ANC, acute necrotic collection, acute peripancreatic fluid collection can be there. More than 4 weeks, they turn into walled off pancreatic necrosis and pseudocyst respectively. Okay.
Okay. Fine. Go ahead. How does alcohol causes acute pancreatitis? Ketarnath?
yes, sir. Alcohol will have it has direct effect on the acinar cells of the pancreas as well as the it will cause spasm of the sphincter of Oddi, sir. Thereby reflects spasm, thereby increasing the ductal hypertension and also causing ductal hypertension and causing pancreatitis, sir. Then direct damage to the direct damage occurs to the acinar cells, sir. Thereby it also alters the triglyceride levels in the blood, sir. Thereby it also causing damage to the pancreas, sir.
What happens to the secretions?
Sir?
What happens to the secretion, pancreatic secretion?
It will increase the pancreatic secretion, sir. Increasing the protein secretion in the pancreatic enzyme.
So increase the secretions, increase the ductal pressure, and sphincter of Oddi spasm.
Yes.
Okay, fine, good. Examination.
General examination. The patient is moderately built and nourished. Is conscious, cooperative, oriented to time, place, and person. Vitals pulse rate 88 beats per minute. BP is 110 by 70 mm of mercury. Temperature 98.6 degree Fahrenheit. Respiratory rate 14 per minute. No pallor, ictus, cyanosis, clubbing, generalized lymphadenopathy, and pigmented edema. Local examination for abdomen. Inspection. After getting consent, patient was examined in supine position, exposing from nipple to mid-thigh in a well-lit room with adequate privacy. Umbilicus midline in position and inverted. All quadrants of the abdomen move equally with respiration. A mass of size 10 × 8 centimeter in the epigastric region. With the skin over the swelling normal and no scar dilated veins of visible peristalsis. On a head raising test, mass appears less prominent. Hernial orifices free. External genitalia appears normal. Palpation, no local rise of temperature, no tenderness. Inspective findings confirmed a mass of size 8 × 10 × 8 centimeter present in the epigastric region, extending vertically from 1 centimeter below the epicenter up to 3 centimeter above the umbilicus. Horizontally, it is extending 3 centimeter on either side of the midline. It is soft in consistency, surface smooth, non-tender, borders well defined. Swelling does not move with respiration. Finger insinuation test positive. Transmitted pulsation present. No organomegaly, no guarding or rigidity, no palpable lymphadenopathy, supraclavicular fossa normal. On percussion, dull node present on percussion over the mass, and liver span was normal. Liver dullness is distinct from that of the mass. No evidence of free fluid or succession pressure. On auscultation, normal bowel sounds present, no audible growth. For rectal examination, tone normal, no mass, fecal staining present. Systemic examination, cardiovascular system S1, S2 plus present, no murmur. Respiratory system bilateral RNT%, no added sounds. Central nervous system, no focal neurological deficit. Summary: a 39-year-old gentleman with complaints of mass in the epigastrium and diffuse dull aching upper abdominal pain for a duration of 2 months associated with vomiting and early satiety with history of similar episodes of pain in the past. On examination, a soft swelling of size 10 × 8 centimeter present in the epigastrium with well-defined borders which does not move with respiration, and finger could be insinuated below the costal margin bilaterally. Provisional diagnosis from the history and examination is a cystic swelling arising from the retroperitoneum, probably pseudocyst of pancreas.
Any differential diagnosis you would like to give?
Is it a swelling arising from retroperitoneum?
Yes, sir. Mass arising.
Swelling arising from retroperitoneum means what do you mean?
Sir, on examination, sir, head tracing test shows.
It's not swelling arising from that. It is only collection of the swelling in the retroperitoneal space.
Okay, sir.
Okay.
So why do you think it's a pseudocyst? I say it's in a peripancreatic fluid collections because he's an alcoholic and he had in a previous episodes of pain like this. Probably I consider an acute pancreatitis and fluid collections, not pseudocyst. Santosh had explained you.
Sir, yes, sir. After 4 weeks of after 4 weeks of an episode of acute pancreatitis, with the fluid collection, there is any cyst formation, pseudocyst. Without
one is the duration. So you think it's beyond the 4 weeks of the beyond the 4 weeks of the acute attack?
Yes, sir. It's 2 months.
Okay. One duration. Next one. One is the duration. Agreed. What else?
Sir, if it is peripancreatic collection, the borders will be well defined.
Very good.
Well defined borders.
Huh?
The borders is well defined, sir. If it's a peripancreatic
in
pseudocyst, sir.
Very
if
good.
it is a peripancreatic collection, the borders won't be well defined.
Yeah, diffuse.
Diffuse borders will be diffuse.
Very good. Anything else?
So differential diagnosis. If it is a younger age group, now we can think of other cystic conditions, cystic swelling like mesenteric cyst, sir.
Mesenteric cyst. You said it's retroperitoneal.
It is intraperitoneal, sir, not retroperitoneal, sir.
No. Why did you bring the mesenteric cyst all here? You said this is a retroperitoneal cyst, probably a pseudocyst. Why suddenly mesenteric cyst?
Yes.
That's where you guys do a mistake in the exam. Once you start mesenteric cyst, I'll keep on asking what is mesenteric cyst, and time waste for you and for the examiner both.
Okay, sir.
Okay. Any other differential diagnosis? He said this. Why not it's cystic neoplasm on the pancreas?
Sir, cystic neoplasm of the pancreas, the duration is small, sir, compared to.
Duration? No. It can be there.
Yes, sir, but it is a pathological finding, sir. We can't.
Pseudocyst is also pathology only. It's not a normal. It's not a physiological.
How do you say it is pseudocyst? Is it clinically, are you able to make it is a pseudocyst?
No.
So it is only pathologically only saying it's a pseudocyst. Why it is pseudocyst, not cyst?
Sir, probably pseudocyst, sir, because the arising.
No. Why it is called as a pseudocyst?
Sir, because it is not lined by a proper epithelium, so it is a fibrous capsule.
Okay.
With the collection, with fluid collections.
We will not be able to see clinically, no?
Yes,
So
sir.
pathological diagnosis.
So why not say cystic neoplasm? What you said is wrong. Because 2 months, no.
So you say the features which are against the cystic neoplasm in this patient.
Yeah.
Sir is just expecting that.
Age, sir, it's a middle-aged man, sir.
Middle-age also cystic neoplasm occurs. Age is not the thing, except IPMN, elderly age group. Sex. Have you seen cystic neoplasms?
No.
No, you're not seen. Okay. Theory at least. Males or female?
Female is more common than male, sir.
More common. Okay, fine. Then what else?
How does it present you?
Yeah.
The predominant complaint in your patient will not be there in cystic neoplasm.
So abdominal pain won't be there. So first there will be swelling, then followed which pain will come.
Incidental. If not, they present as mass.
Okay.
Most of the times they're incidental, asymptomatic.
Okay.
And they do not attain this big size, except which cystic neoplasm?
Cystic neoplasm.
No, SPEN.
No.
Solid papillary epithelial neoplasia. SPEN. They attain this big. Okay. Fine. So how do you? What next?
Sir,
what shall we do?
So we'll go for investigation.
Remove that mesenteric cyst.
Sir?
Don't say in the examination mesenteric cyst. Okay?
Okay. Okay, sir.
Okay, fine. So how do you investigate?
Sir, I will do a complete blood count for the patient, sir. I'll do renal function test, liver function test, serum amylase, serum lipase, and serum calcium level.
Amylase, lipase, calcium. Why do you want all these things? It's not an acute pancreatitis. Why do you want all these? Amylase, lipase, waste of money. Calcium.
First, you confirm your diagnosis, then you go for all this if it is necessary.
Okay, sir. I'll do ultrasound abdomen first.
Okay. You have mentioned X-ray the abdomen. You don't want that? Erect. Specifically mentioned erect.
Yes.
Why do you know?
Yes, sir.
What will you know?
Sir, it's emergency.
There is something, that's why I'm asking you. You're rightly written X-ray the abdomen, not erect, X-ray the abdomen. So what findings will help you in diagnosing pseudocyst? And is a chronic alcoholic.
Sir, that in case of chronic alcoholic with chronic pancreatitis, there'll be ductally there'll be stones, chain of plaque appearance will be there.
Calcification may be there.
Yes, calcification. Yes, sir.
So it means
chain of plaque appears in ERCP MRCP. Please don't mention that. Okay. You will see ductal calcifications, ductal or parenchymal calcification.
Okay, sir.
The calcification, if you see, it indicates probably a chronic pancreatitis. In history also, you forgot to mention this patient does not have any diabetes and also exocrine deficiency. It's important. Steatory is important in this patient because he's a chronic alcoholic as well as is emaciated. I've seen this picture. I see skin and bone. A thin guy.
He was not nourished, sir.
Yeah.
He was poor.
Yes, poorly nourished. So I'm sure he must be having exocrine deficiency and diabetes. Okay. Fine. What next?
I'll do ultrasound of the abdomen and pelvis, sir.
So why do you want to know ultrasound of the abdomen?
Sir, I want to know the characteristic of the swelling, sir.
One, whether it's cystic or solid.
Yes, sir.
One.
Then it's location, sir.
Okay, location. I agree. Okay. How does it matter, location?
Sir, and sir, whether I want to do it, the swelling is compressing any adjacent structures, sir.
No. Location. How does it matter for you?
Sir, location, I can plan for any drainage in future. If I want to intervene.
Okay, if you want to intervene, maybe it will be useful. Okay, fine. What else?
I would also like to see the other calculi in the GB and CBD, sir.
I'm not interested in GB calc. I'm interested in the parenchyma, pancreatic parenchyma, if it's possible to see.
Yes, sir.
I would like to know whether there are any hyperechoic lesions there in the pancreas. I would like to know if there's any duct is dilated in this patient. I would like to know whether the liver is normal or cirrhotic in this patient. I'd like to know about the spleen is normal or enlarged. Why all these things?
So portal hypertension, sir.
Yes, need to rule out portal hypertension because it's taking alcohol for quite a long time. Okay. And one more is pseudoaneurysm. As you rightly said initially, need to rule out the pseudoaneurysms also. Sometimes they may be associated with that. Okay, fine. What is the ultrasound report? You have?
Sir, the ultrasound report was 10. It was 10 cross 5 centimeter. 10 cross 5 centimeter hyperechoic lesion involving the body of pancreas, sir.
Hyperechoic.
Yes, sir.
Okay.
Are you sure? Is it hyperechoic?
Yes. Yes, sir.
What does it mean by hyperechoic? If I had said it's a simple cystic lesion found in the pancreas, 10 into 5 centimeters, I would have been very happy. Instead, you said hyperechoic lesion. So I have a lot of doubts in my brain.
Okay, fine. How does a cyst appear in an ultrasound? Whether it is hypoechoic, whether it is anechoic, or whether it is hyperechoic. Usually, by and large.
Say simple cyst, how does it look like? Simple cyst of the liver, how does it look like on ultrasound? No pus, no solid element, clear fluid.
Nothing.
Giving
How
hint.
does it look?
So
You're actually doing about now. You're doing good only.
Anechoic, isoechoic, hyperechoic.
Simple liver cyst.
It doesn't know. It doesn't.
Okay, it's okay. It's okay. Take it. And yeah, what else? 10 into 5 centimeter cystic lesion.
involving the body of pancreas, sir.
May not be correct. It's not an hyperechoic, maybe isoechoic or anechoic. Okay.
You also see for any structures within the cyst, solid lesions or solid contents.
If there is a solid content, okay, we have found solid content in that. So your definition of pseudocyst is wrong, or you would like to revise your diagnosis?
Sir, maybe it may be due to necrosis, sir.
You should consider, no? You should consider probably a ward of necrosis.
Ward of necrosis, you have to think.
Yes, sir.
Okay. Okay. What else? Sir. What else you found on the ultrasound apart from this?
Sir, then they said like main pancreatic duct was not dilated, sir.
Why it is important? Main pancreatic duct dilated or stone covered. How does it matter for you?
Sir, Sir, as I said, in case of any obstruction, sir, in case of any obstruction, there will be dilatation. There will be distal dilatation of the pancreatic duct, sir.
How do you classify pseudocystal pancreatitis? Now you'll come to know all those things. If you
So communicating and non-communicating types, sir.
One. Basically, classification is based on the structural change of the duct, whether it is communicating with the pseudocyst or not. So like that, 1, 2, 3, 4, 5, 6 are there. Now you tell me, how do you classify pseudocyst? This is how we classified. Imaging classification.
So DEGDO classification, there are 3 types, sir. Following acute attack of pancreatitis, there will be normal ductal anatomy without any stricture formation. Second, there will be damage to the duct.
Type 1 is normal duct and cyst, no communication.
No communication, sir.
Very good. Then
type 2 is duct, then 50% chance of stricture formation, no fistula formation. Type 3, there is there is communication as well.
No, you are wrong. I think you need to read again. So I said ductal changes, communication is most important. So ductal change, no communication. Communication with normal duct, and then ductal changes, no communication, and then ductal change with communication, and then stricture and chronic pancreatitis. That's how it's classified. Type 1, 2, 3, 4, 5, 6. Please go and read again.
Okay.
Okay. How does it matter for you? Why do we need to classify pseudocystic pancreas?
So whether if it is communicating, it won't resolve, sir.
Communicating, it won't
resolve by itself.
It will not resolve. One of the reason for not resolving because of a communication with the duct.
Yes,
fine, very good. What else? Why do we need to classify?
Is it going to change the way you manage it? Or is it going to change surgery or any intervention you do?
Yes, if it is communicating, we can use pancreatic duct. We can apply stent, sir, and then it will reduce.
You're a surgeon. If the pseudocyst following an acute pancreatitis, what is the treatment?
So
no ductal communication.
So depending upon the location, I will do either internal drainage or external drainage, sir. Internal drainage, I will do either cystogastrostomy or cystogenostomy or cystoduodenostomy.
Okay. So for the management purpose, we need to classify. We need to know whether the pseudocyst is formed because of acute pancreatitis or because of chronic pancreatitis. So if there's a chronic pancreatitis and ductal communication, we need to do an internal drainage. The external drainage are very rare nowadays. We don't do external drainage. It's always we have an endoscopic drainage, interventional radiologist, and surgical drainage. There are the 3 kinds of interventions. External drainage nowadays is rare unless cyst is got infected and patient is in sepsis, not fit for any surgery. We might do an external drainage. Otherwise, most of the times it's an internal drainage. Okay. Suppose chronic pancreatitis with the pseudocyst, how do you manage?
So cyst in the tail of pancreas, you do an internal drainage, sir?
Yes, sir. Yes, sir. Cystogenostomy. And again, depends like symptomatic or non-symptomatic. Asymptomatic cyst, we will not drain. Symptomatic cyst, yes, we do intervene, sir. So this patient has a vomiting. This patient has a pain. So he needs an intervention.
The patient in moribund condition were not fit for surgery.
That's what external drainage. That's what external drainage.
You can do an external.
Yeah, external drainage. Not fit for or infected, septic. So basically, external drainage.
Yes, Kedarnath, continue.
Yeah, Kedarnath.
Yes, sir.
Suppose patient has a chronic pancreatitis and pseudocyst. So how do you manage?
Sir, we can first we have to decompress the ductal hypertension, sir, by approximately so pancreatic jesnostomy we will do, sir.
Yeah. So most of the times chronic pancreatitis will have cyst will have a communication with the duct. So we need to decompress both the duct as well as the pseudocyst. Simple pseudocyst drainage may not be helpful sometimes. So we need to tackle both the duct as well as cyst. Sir, any question? Ketanat, do you have any questions, doubts?
No, what was done in this case? What was the finding? Show the picture for them. You explain.
Suppose you do the cystogastrostomy.
Yes,
the
sir.
second time when the patient is taking oral feeds, will it not go to the cyst?
No, sir.
Why?
Sir, basically because of the gastric peristalsis, sir, and there's also effect of Venturi effect, sir, wherein when there's a patent natural orifice, it won't go to the other orifice.
Side holes.
Right.
The concept of original that rule of 6 is now not been followed. The 6 centimeter thick, 6 millimeter thickness, 6 weeks.
Symptoms or no symptoms? Symptoms in terms of compression. Like this patient has a vomiting. So we need to intervene. Symptoms of pain. So infection. Jaundice, yes. Yeah. Can you read the CT?
Yes, sir. This is a pancreatic protocol CT showing pseudocyst in the involving the body of pancreas, which has displaced the stomach
hypotense
yes.
lesion, unless there are no Hansfield units there. Okay, go ahead.
This has disposed the stomach towards the laterally towards the left, sir.
Anteriorly.
Anteriorly, yes, anteriorly.
Okay. What else? You have only one picture, or you have some more?
Even in this, you can see something about pancreas. So I discussed no chronic.
Yes, sir. Pancreatic parenchyma is thinned out, sir.
Okay, ductal dilatation, calcification, those things you can see.
Sir, there is one calcification. There is calcification present, sir.
Actually, you can comment that only in plain film. Okay, I think it is arterial. Yeah, if I'm not wrong, it is arterial phase.
Yeah, what else? What is important? Suppose forget about all the history and all. This kind of an CT scan is given, and you find a cystic lesion like this. What are the things you look for?
Sir, I will look for number of cystic lesions, sir.
Okay.
Location, site, number of swelling. Then it's the proximity of the cyst and the stomach, sir.
Okay.
And thickness of the wall, sir, cyst wall.
Okay. Okay. And the distance from the stomach or duodenum is also important.
Yes.
It should be less than 1 centimeter for any intervention.
Yes, sir.
What else?
So any
solid component.
Okay, sir.
Loculations.
Sure.
Loculations, presence of septate. Loculations and septate. Septate indicates sometimes infection. So we need to. I said if this kind of a CT scan is given. So what are the things you ask for? You mentioned many things. In addition to that, you need to look for an septate, whether enhancing septate or not, and also look for a necrosum, and also look for an intramural nodules. Sometimes we may find, not in this patient, because his typical history of alcoholism is there, acute pain is there. It's definitely in a pseudocyst. However, in cystic neoplasm, these are all the things we look. Okay, what intervention we do now for this patient after seeing CT scan? You want to do a surgery or you want to do anything else now?
Sir, I would prefer to do surgery, sir. I'll do cystogastroscopy for this patient.
Fine. If that is the protocol in your institution, it's fine. But it is endoscopically amenable, and there is a good impression in the stomach. So it can be drained endoscopically also.
Okay, sir.
Any questions, Kedarnath?
No,
Yeah, any doubts?
I just want to ask Kedarnath, suppose the patient suddenly develops a splenomegaly.
Sir.
What will you think of? What could be the reason?
Sir,
Me, sir, or Kedarnath?
Kedarnath.
Kedarnath, yeah.
Sir, probably be portal hypertension, sir. The first word portal hypertension, sir.
Okay. Due to? Due to?
Due to splenic artery.
Very good. Splenic artery thrombosis.
Yes,
Think of splenic artery thrombosis.
Splenic vein or splenic artery?
Vein.
Kedarnath artery, vein.
Splenic vein thrombosis.
Splenic vein.
Splenic vein, sorry, splenic vein.
Yeah, it's called as sinistral hypertension. Now left side.
Yes. Sinistral. Sinistral means right, left-handed.
Can I inform Panilma?
The left side is portal.
Can a pseudocyst produce obstructive jaundice? Can a pseudocyst produce obstructive jaundice?
Yes, if involving the head of pancreas, it impinges on the common bile duct, it can produce obstructive jaundice.
So what will you do for suppose patient has a bleed, varices and bleed, and pseudocyst is there? So what will you do?
Sure, first
endoscopy showed in a varices, and
embolization of the embolization can be done.
Embolization of what?
Embolization of the.
I mean portal hypertension. I'm asking portal hypertension, left-sided portal hypertension, secondary to splenic vein thrombosis because of the repeated acute pancreatitis. So how do you manage? Embolization will not come here. Embolization is for a pseudoaneurysm, not for portal hypertension.
Sir is actually asking, is there any difference in managing varices which develop due to cirrhosis and which develop due to sinistral hypertension, splenic vein thrombosis? Is there a difference in the management?
You can explain some of this, sir. You can explain.
The left-sided portal hypertension, if you do a splenectomy, that's enough. There's no need for any devascularization or shunting procedures. Whereas portal hypertension, because of a cirrhosis or extrahepatic portal vein obstructions, we need to do an splenectomy and shunting or a non-selective shunts. So for sinistral hypertension, if the patient is bleeding, symptomatic portal hypertension, then we need to do left-sided, splenectomy and devasc. Devasc in the sense you will be anyhow ligating the splenic short gastric vessels, that's enough. There's no need for an extensive devascularization. Am I correct, Santosh?
Yes, sir. Just in sinistral hypertension, the spleen receives blood through splenic artery, but it is not effectively able to drain through splenic vein. That is why alternatively it drains through the short gastric vessels, forming varices in the stomach. So if we do splenectomy, and as you rightly said, the short gastric vessel ligation, that will do, sir. Which is not so for the portal hypertension, which develops due to cirrhosis or non-cirrhotic portal hypertension.
Extrahepatic portal vein. The NCPF or
EHPU.
You want to ask any doubts, Kedarnath?
No.
What happens following a trauma? The patient develops following a trauma, pseudocyst. How do you manage?
Sir, I have one.
Huh?
Sir, I have one.
Sir is asking a question.
I'm asking question.
Yes, sir.
pancreatic trauma, ductal disruption, and the pseudocyst is there. How do you manage?
So if we can do pancreatitis.
No, in
Okay.
pseudocyst.
Pseudocyst.
If it is a rupture of the pseudocyst, we can just drain the collection, sir.
What is disconnected duct syndrome? Any idea?
No.
Okay. Yeah, you said you have one doubt.
Yes, sir. So there will be increased the pressure in the pseudocyst will be more than the pressure in the stomach, sir. How does it happen, sir?
I didn't get it. Stomach, more pressure, more peristaltic.
The pressure gradient.
Cystic gastrostom. There is more pressure gradient in stomach. Yes.
Yes.
That's why food doesn't go into the system.
Sure.
Once it is decompressed, once pseudocyst is decompressed, the pressure is zero there. So obviously, more pressure in the stomach. It collapses. No? Once pseudocyst is drained, it collapses.
Okay.
You're right.
If it is
because of the
not a walled pancreatic necrosis, in a pseudocyst, once you decompress, it completely collapses. Its wall becomes the wall of stomach. We have even done sleeve gastrectomy in patient who has undergone cystogastrostomy from 20-25 years back without any evidence of a remaining cyst. It will just merge like a wall of stomach per se, if it is effectively drained.
Yeah. Okay.
Kanavel, sir.
Kate, do you have any other doubts, ma?
No, sir.
Faculty, any other comments?
Thanks for the opportunity, sir. Like, I'm a very young guy in presence of veterans like you all, and thanks for this opportunity, sir.
Okay.
Thanks for you. Thanks for Srinivasan, sir.
Pleasure having you, sir. We look forward for more.
We'll be calling you for any history.
Sure, sir.
Thank
Mr.
you,
Birappa, sir, can we call a close, sir?
Yeah. Thank you, sir. Thank you very much.
Thank you very much, sir. Sahai, sir, thank you very much. Srinivasan, sir, thank you, sir. Santosh, sir, thank you very much. And thank Arun and Kate for joining us this evening. And thank you all of you in the YouTube for joining us this evening. Bye-bye. Good night.
Good night. Thank you.